Cardiorespiratory arrest is intuitively an easier concept to understand than brain death. If we can't restart the heart, then we know the outcome is fatal, that the patient will never wake up. But even this seemingly straightforward definition of death has complexity. When is the actual point of death during this process? What is the point of no return? We are actually using this definition of death as a surrogate marker for irrecoverable neurological damage. With no circulation or respiration, there will invariably be a loss of consciousness and ultimately permanent brain damage. Brain tissue is exquisitely sensitive. Most doctors will wait a period of 5 minutes with no cardiac output and no respiration seen before certifying a patient dead on the basis of cardiorespiratory criteria. This is actually a conservative time period according to the science. We know that after just 15 seconds of absent blood flow to the cerebral circulation, consciousness is lost. We also know that 65 seconds is the longest observed absence of cardiopulmonary function, followed by spontaneous recovery of circulation. This time period may seem inordinately short, but what is important to understand is that 65 seconds is the limit for spontaneous recovery of circulation in the absence of resuscitative efforts and in a setting where you have monitoring to tell you where the exact point of complete loss of cardiac output occurred. Successful recovery can occur after a longer period of time, but this is always in the setting where doctors are intervening to change a reversible event and supportive therapies have been instituted. Very often, there has not yet been a complete loss of cardiac output. Doctors only look at the clock when all treatment options have been explored, not before. As we have seen with brain death certification, however, it's not enough to simply pronounce someone dead. There needs to be acceptance, and this varies between countries. As such, the time doctors are required to wait before certifying someone dead on the basis of circulatory criteria differs from country to country. In the United Kingdom, Canada and South Africa, the time period is 5 minutes. In Italy, it's 20 minutes. The Australian guidelines state that the time period must be no shorter than 2 minutes and no longer than 5 minutes. Many countries, unfortunately, do not specify a time period and leave it to the discretion of the treating doctor. In the United Kingdom, guidelines for circulatory death determination were only published for the first time by the Academy of Medical Royal Colleges in 1997. These guidelines state that for death to be certified on circulatory grounds, one of the following preconditions must be met. The individual must either meet the criteria for not attempting cardiopulmonary resuscitation, or attempts at cardiopulmonary resuscitation have failed, or treatment aimed at sustaining life has been withdrawn because it had been decided to be of no benefit to the patient and not in his or her best interest to continue. In the primary care setting, the absence of mechanical cardiac function is determined by a combination of the following: the absence of a central pulse on palpation and the absence of heart sounds on auscultation. In the hospital and ICU setting, clinical signs can be supplemented by evidence of asystole on a continuous ECG display, absence of pulsatile flow on direct intraarterial pressure monitoring, or the absence of contractile activity on echocardiography. Any spontaneous return of cardiac or respiratory activity during the 5-minute observation period requires a further 5 minutes of observation. Only after this 5 minutes has been fully passed can the absence of papillary response to light, corneal response to light touch, and the absence of any motor response to supraorbital pressure be confirmed. The guideline also goes on to specifically state that intervention to restore cerebral perfusion after death has been confirmed is inappropriate. You might ask, why even have this last statement? Surely the patient is already dead, and medical technology cannot bring them back to life. You would be correct, but it is important to make this statement because medical technology has advanced to the point where machines can take over circulation in addition to ventilation. The most basic of these mechanically compress the sternum, achieving the same effect as manual compressions during CPR. These particular devices are quite crude. Remember that chest compressions delivered to the correct depth to maintain cardiac output in adults invariably fractures multiple ribs. It's always disconcerting when you hear and feel broken ribs while doing CPR. Newer therapies, such as extracorporeal membrane oxygenation, or ECMO, are akin to cardiopulmonary bypass and are much more elegant in their operation. Termed eCPR, if used in the resuscitation setting, ECMO can potentially be run in the ICU for months at a time. But as with most ICU treatments, these are not solutions in themselves. They are temporizing, supportive measures to give you time to treat the patient and buy time for the patient to recover. Instituting these supportive therapies in situations where there is no route to recovery is macabre and wrong. Similar to brain death, we can now be faced with a situation where we can take over organ function, in this case the heart, but may never be able to restore the patient to independent living. Forever to have their chest compressed mechanically or to have their blood drained out and pumped back in, as long as the electricity holds out, is not a long-term solution. Removing such methods of support when there is no residual cardiac function results in immediate cessation of circulation. For some reason, this is not nearly as emotive as withdrawal of mechanical ventilation. As doctors, we must always be aware of the limits of our medical therapy. Our interventions must be governed by the outcome measure of restoring the patient to what for them would be a meaningful existence. When it comes to treating patients at the end of their life, our patients and their families simply want to know that all appropriate treatment options have been explored, that it is truly the patient's time to go. No one is asking for CPR to be continued indefinitely. We would all like to be declared brain dead at the appropriate time. When determining death by circulatory criteria, this is when the initiation of or continuation of ongoing resuscitation and treatment is futile, and an agreed upon time of observation has passed to exclude the chance of spontaneous recovery. If no respirations or cardiac output is detected during this observation period, and there is no response to pupillary, corneal, or painful stimuli, then the patient can be declared dead on the basis of circulatory criteria.